Okay, good morning, everybody. And this morning we're going to be discussing something which is, of course, of immense importance to us at the moment. And this is the current epidemic of this coronavirus, and also referred to as a novel coronavirus, literally because it is a new entry into the human population of this particular virus. And I want to tell you a bit about the virus and try and explain something about the epidemiology of the virus. That is, try and explain something about the spread of the virus. Also, I hope to be able to lay to rest some of the myths that have come to surround this virus and this epidemic. First of all, let me explain to you that this is a coronavirus. The coronaviruses are a well-known group of viruses. They all have relatively similar structure when you see them under an electron microscope. They're an enveloped virus, that is, they have an envelope around the innards of the virus, which is derived from the host and embedded in that membrane. Are all of these proteins, which are viral proteins, these red colored here. When you look at this under an electron microscope, then these create a sort of a haze around the virus, which to early workers looked like a crown. And that is how it got the name corona. Corona means crown. This coronavirus. This is a member of a group of viruses, some of which have caused illness in human population before, as I'll explain to you. It is extremely similar to a very, very virulent virus, which we sought in 15 years ago into the human population, called SARS, severe acute respiratory syndrome. And this disease, SARS, the original SARS, was so severe that it had a very, very high mortality rate. But it had there were not that many people infected by it. It did spread worldwide through travel, but it never established a pandemic. It never established true epidemic proportions, largely because it was so incredibly severe, as I'll explain in a minute. So the current virus is SARS, severe acute respiratory syndrome, coronavirus, CoV-2. The original SARS is CoV-1. The current one is CoV-2. And just to show you a little bit about the epidemiology of it, these are the current case loads in the United States. I downloaded this on November 22nd. And you can look this up every day on the New York Times website. It is available to you to see. So let me explain first of all. When you just record the numbers per day, the numbers tend to bounce around a little bit because of reporting errors and things like that. So in epidemiology, very often we'll take an average, and this is a 7-day rolling average for the number of cases. What we can see is a very, very, very disturbing trend. First of all, here, this is for the whole nation, not for New York. New York's curve was looked a little bit different, as I'll explain. This is the national trend. Here is the spring, April, May. The virus entered the American population at the beginning of the year. So there are very low caseloads there. You can see here, though, there's a very rapid increase. If we were to blow this up, we would see it was a curve like this. And that is because there is exponential growth. That initial curve was flattened. Most of this was on the West Coast and here in New York, where there was very, very good public compliance with recommendations from the epidemiological authorities. People were quite good about wearing masks, socially distancing and everything. And this is what we mean by flattening the curve. The 7-day average for case numbers actually was decreased. The importance of this is not only that you reduce the number of people who are infected, but that you reduce the impact on health services. Because if health services are suddenly overwhelmed with a huge number of cases, they simply cannot cope. If you've got 20 people who require an intensive care unit bed, and you've only got 10 ICU beds, some cruel decision has to be made about who are the 10 who do not get to lie in the ICU bed. And a reasoning has to be developed for why they should be denied. In July, it kind of remained much the same. The important thing to realize here is that the virus is very much present in the population and is available to spread out now to vulnerable persons in the population. In the summer, we saw a massive increase in the number of cases. And again, there was some flattening of the curve, but as we have approached fall and winter, this has just exploded nationwide. And much of this increase here, you can see, is it's what we would refer to as being exponential. Exponential growth means that it is uncontrolled growth. An exponential curve would be described, for example, if I had 2 cells that divided to 4 cells, that divided to 8 cells, that divided to 16, 32, 64, etc., etc., etc. That would give me exponential growth. That is what we're looking at here, more or less a doubling every couple of days, in fact, of the case load. Nationwide, there have been 12.1 million cases. That's more now because this was November 22nd. And there have now been close to 260,000 deaths, I saw today. We are looking at a very, very, very active epidemic in the nation, but we're looking at the same kinds of figures worldwide. So we are looking at a pandemic. The infection has spread worldwide, and we're seeing similar patterns in many places in the world. Far worse in the United States than elsewhere, for reasons that we need to think about. We need to think about why we were successful here, where we have failed here, and we have dismally failed here to control the spread of the virus. You can see here are the hospitalization figures, and this is people currently hospitalized. This is placing an enormous strain on the hospital services, and especially on the limiting factor in hospital services, which is personnel. Personnel in hospitals have been dealing with a very, very difficult situation since the beginning of the year, since March, and are only seeing it getting worse, not seeing it get better. We'll need to talk about some of the reasons why that is the case. Okay, so let's just think for a while about the virus itself, and about where on earth does this virus come from? Why is its impact so enormous? Well, first of all, the coronaviruses are very well known and very well characterized. Most of them that are already known occur in animal populations, and some of them occasionally spread to human beings. There are 4 well-known human coronaviruses, and these are the coronaviruses that have been known for decades. to cause the common cold. Remember, there are 200 viruses, over 200 different kinds of virus that can cause the symptoms of the common cold. 4 of them are coronaviruses, and we've known about them for a long time. They only cause mild illness. They do not cause serious illness at all. But over the last few decades, a number of these new coronaviruses, novel coronaviruses, have entered the human population, and they have resulted in diseases which are far more serious than those 4 coronaviruses that cause the common cold. And the first is SARS CoV-1, and SARS CoV-1 is the original SARS, and had a very, very high mortality rate. It is believed to have entered the human population, again, through contact with an animal. That is, its origin is a zoonosis, as a zoonosis, something that originated in an animal population. Exactly which it is not certain. It was attributed to an animal called a civet, but that is not certain. We are pretty sure that it came from human contact with an animal, a wild animal population. No. These viruses occur in wild animals, but they are very well tolerated in those populations. Unfortunately, coronaviruses are promiscuous. That is, they can move from an animal population to a human population. And they can move in such a way that once they enter a human population, humans can then infect other humans. This is a very important step. There are many viruses which can enter the human population, but they end at their first infection because the human being cannot spread to another human being, just the nature of the virus. But the SARS virus could be spread. It was contagious. However, not nearly as contagious as our current coronavirus. There's SARS CoV-1. There are many coronaviruses recorded in other animal populations, in pigs, all sorts of things, which don't spread to humans. Here, this is the other one which we are interested in. This is called Middle East Respiratory Syndrome. And Middle East Respiratory Syndrome is a very, very virulent coronavirus, but and it is acquired, is believed, it is acquired from camels. Very, very limited in its distribution. It does not establish epidemic proportions, but it can be spread. But the spread between human beings appears to be limited. So it does not establish it. So we've got SARS CoV-1, Middle East Respiratory Syndrome is the other. And now our current epidemic and pandemic virus, SARS CoV-2. Now, SARS CoV-2, again, its immediate origin is believed to be animal populations. It is suspected an animal called a pangolin. But there is something very interesting about all of these coronaviruses, and that is that they appear all to have originated originally in bats. Bats harbor many, many, many coronaviruses, which they tolerate very well and don't make them particularly ill. But contact between bats and intermediary animals seems to be a route whereby they can be spread to a human population. So here they are, the whole range of coronaviruses. We have these 4 that only cause mild illness, and then we have these others which cause very, very serious illness. And these 2, CoV-1 and MERS, the disease is so severe and the onset of symptoms so rapid that patients tend to be isolated, recognized and isolated very, very quickly, which means that we limit the spread of the disease. There is a major problem with our current coronavirus, and that is SARS CoV-2, our current coronavirus we're dealing with, has a long period where people may be asymptomatic and can spread the disease around because it is highly, highly contagious. It is even more contagious than these. So that is a major problem. And so here's the virus, just to remind you. They all look pretty much like this, but remember that each of them has very, very specific characteristics. They have an envelope derived from host cells, as I'll show you in a minute. Embedded in that membrane are these viral proteins. There are a number of viral proteins, but the one that we are particularly interested in for our purposes is this one here. Are these rib-colored ones colored red here, which are called the spike proteins. These are the proteins which enable the virus to identify the correct host cell that it must infect. They infect particular cells in which they can reproduce. And in order to infect them, they have to adhere to them and then gain entry to the cell. And that is governed by these proteins, the spike proteins and other proteins in them embedded in this membrane. We are also very interested in these proteins because these are proteins which our immune system would see. And we can try to use these proteins to develop vaccines. And all of the vaccines that we are currently hearing about are vaccines which are designed to recognize these proteins on the outside of the virus. Okay, so here are all of its innards. First of all, here's the membrane derived from host membrane around the outside. Embedded in it are the proteins, spike proteins, and then there are other proteins as well, you must remember. On the inside of the virus, there's this helical capsid made of protein. And inside that helical capsid of protein, there is a RNA strand. RNA, excuse me. RNA is a nucleic acid. It's the hereditary material of this virus. This is a group of viruses which use RNA as their hereditary material, and that lies on the inside of the spiral protein capsid on the inside. So the virus, in order to establish infection, it has to first of all move into a host. Inside the host, it has to find the correct cells to infect. It has to somehow gain entry into the cells. And this is actually a relatively complex process. We'll obviously just think about it relatively simply. Okay, so if you are unfortunate enough to inhale the viral particles, first of all, it must be said that you need many viral particles. Many of the viruses will attempt to establish infection and will fail. So you need a minimum dose of viral particles to establish an infection. It's not going to happen probably with just one virus going into your nose. You'll probably need hundreds of thousands in order to have some of them establish a successful infection. Here's the virus here. These spike proteins on the outside recognize a particular protein embedded in our own membranes, in the membranes of certain of our cells. Not all of our cells have these proteins embedded in their membrane, so not all cells can be infected by the virus. It requires this particular protein. It's called the ACE2 protein, and the spike proteins stick to this, and they get the cell. Don't worry about this, by the way. This is from an experimental paper, and that's just something they were busy doing. But the virus sticks to this protein here, and it induces the cell to fold in like this and actually swallow the whole virus. So it swallows the virus as if it was eating it. It takes it into a vesicle, which is then moved into the cytoplasm of the cell. So here it goes here. You can imagine this. Here is sticking to the ACE2 protein there. You can imagine it swallows it like this, and it ends up forming a vesicle like that. And the membrane of the virus then joins this membrane here and opens up and spits out the genome, the hereditary material. And those proteins of the capsid are digested off. And now we have an RNA strand inside the cytoplasm. Think back. Think back. I told you what happened when the cell sees messenger RNA. When it sees RNA inside the cell, it starts to translate it. It starts to read the hereditary information, and it will start to produce viral proteins. So that's exactly what happens. The cell starts to read off the viral proteins. And in addition, the virus has its own protein, which will replicate the RNA. So it, first of all, starts reading off proteins, which are viral proteins. Second of all, it starts producing masses of copies of its own RNA, of its own genome. Those proteins that it makes are actually moved to and matured at the endoplasmic reticulum. Go back, see what the endoplasmic reticulum did. That's its responsibility, is maturing proteins. The viral proteins are matured at the endoplasmic reticulum and at the Golgi apparatus. And the viral proteins are embedded in membrane, and the Golgi then buds off vesicles like this. And the membrane that we see around a coronavirus is actually derived from membranes from the endoplasmic reticulum and the Golgi apparatus, as you see here. So the Golgi apparatus, here it's budding off a vesicle like this, and on the inside of the vesicle, there is a new viral particle. There's the membrane with proteins embedded in it, viral proteins embedded in it. It encloses the genome in its own protein, now invested with its own protein capsid. And here is the mature virus particle. So what has happened? The virus has injected its genome. It replicates its genome. It gets the cell to make all of the correct viral proteins to enclose in a capsid and then in a membrane. And it buds off a new viral particle. Membrane here derived from endoplasmic reticulum and Golgi, but with viral proteins embedded in it. And it now moves that to the surface of the cell where the virus is released. So that's the whole infection cycle inside a cell. I must tell you, though, that the kinds of cells which get infected by this virus is very interesting. Some of them are obvious. The first thing is that it establishes infections through respiratory tract, through the cells of the respiratory tract, and they can infect the cells, widely infect the cells of the respiratory tract, because the cells of the respiratory tract have this protein present. But the virus can also infect blood vessels. It can infect cells which line the blood vessels. You'll think back and remember that word, endothelial cells, the lining of the blood vessels. It can also infect heart tissue. and there is some suspicion that it may be able to infect nerve tissues, some nerve tissues as well, or at least cells associated with the brain. So it is the number of cells it infects is quite wide, but just think of what you have read about some of the symptoms of COVID-19, and you'll realize, first of all, the respiratory tract, that infection is what produces most of the predominant symptoms, which are dry cough and that sort of thing. But some of the very dangerous effects of this virus are produced by its infection of things like the blood vessel lining, which cause clotting disorders and all sorts of other things. Can have some very, very serious impacts on far away from the respiratory tract. So here are some of the predominant symptoms of coronavirus. First of all, in many, many people, the disease remains limited, and the symptoms can, in fact, be extremely mild. This in itself makes this disease extremely dangerous because there is a lengthy period of infection after infection when people may actually be producing virus. The virus may be reproducing, but they have little idea that anything is wrong, and they can be spreading the virus for quite a long time before they themselves realize that they are ill, if they ever realize that they are ill. You will know, of course, that because of the huge number of deaths that we've seen in the nation, now approaching 270,000 deaths, that it can become extremely serious in some people, and I'll discuss with you why that is. It is particularly dangerous in the elderly and in the very, very young. That is typical for many, many viruses. But its infection of very young people appears to be quite low. So infants and young children appear to have a lower infection rate. But in the elderly, its infection rates are high, and the death rate is high. But that is not to say that the death rate is low amongst other groups. In fact, the mortality rate of the disease overall is about 2% of people who get the disease. Currently about 2% die. So here are the symptoms. The predominant symptom, first symptom to be noted, is this one, which is fever. And more than 80% of people infected who become symptomatic. Remember, many people stay asymptomatic. The predominant symptom is fever. The next ones are, first of all, dry cough is the next most common. 68% of people end up with this dry cough, and it's called a recalcitrant cough. It's very difficult to control even if you're taking cough syrups or anti-cough medicines. The next is this, which is fatigue. Nearly 40% of people report extreme fatigue. And the one symptom which marks very often the beginning of serious illness is this one here, which is shortness of breath. When the virus infects the lung tissues themselves, their ability to take up oxygen is impacted, and people then begin to suffer from a shortness of breath. The other symptoms are scattered and very varied, and actually occur only in a minority. Some symptoms which you'd think would be common are not that common. Headache, for example, is not that common, only 14% of cases. Gastrointestinal, very few. You see here vomiting, diarrhea, very few cases. Associated with the lungs is this here, very often associated with this cough. As the cough proceeds, then people start to produce phlegm, heavy mucus production in the lungs, often as a somewhat later symptom after the dry cough. So it's a real mixture of different symptoms. And really, in trying to diagnose by symptom, medical personnel will look for key markers: fever, fatigue, dry cough in the early times, shortness of breath as it proceeds, and then maybe a productive cough later on. This means that this disease is actually quite easily confused with many other respiratory syndromes, right? Many of these features here you might also think are associated with things like influenza. So a distinction needs to be made when a patient presents, say, at an emergency room with some of these, say they've got fever, they've got headache, they've got a cough, and they're fatigued, maybe they've got a bit of joint pain, whatever. That also looks like influenza. And people may, in fact, be tested then to establish exactly which virus are we dealing with. But coronavirus, especially as it proceeds to more serious illness, has some very distinctive features to it. So let's go, because we're entering the winter season, it is quite possible that some of us are going to get influenza, especially if you haven't had your flu vaccine, which you should all do. If you get something like flu or whatever, it's easy to confuse it and then be panicked because you think that you have COVID. There are ways to distinguish, even without testing for the virus, the identity of the virus itself. There are some differences. So, for example, let's just compare to all these being the common kind of respiratory things that people have: common cold, influenza, and allergies can all produce these kinds of symptoms. So the first thing to note, our primary symptom for COVID is fever. In the common cold, you very seldom get fever. It may get a very, very mild fever, but it's very rare. But it is a very common feature of influenza. It's uncommon with allergies unless the allergy is extremely severe. So it shares fever with flu. The dry cough, in the common cold, you can get a cough, but it's often only later as a result of a secondary infection. The common cold itself seldom produces severe coughing. But in influenza, it is common. It is common to develop a cough just as a result of the virus itself. Allergies, maybe if you suffer from asthma or something like this, you might develop a cough, but it's rare. Here's a distinguishing feature. In COVID-19, the shortness of breath, the development of shortness of breath becomes more common if the infection proceeds. And that is very rare. It's unheard of in the common cold. Very rare in influenza to develop shortness of breath. But in allergies, as for instance, asthma, things like that, it is common, but you would not have these. Headaches In COVID-19, actually, headache is not that common. Some people do. Common cold, mild headache, but not anything marked. But it is a primary symptom of influenza, and very, very often the very first symptom of influenza is the sudden onset of severe headache. That is often the very first sign people have that they're infected with flu virus. They develop a sudden, very strong headache. That is not common in COVID. Aches, pains, yes, they all share. Sore throat, it's not actually common with COVID, very common with common cold and with influenza. So any medical personnel, they would need to look at the whole range of symptoms that a person suffered from, and then make a decision as to whether they were likely suffering from influenza, common cold, or just allergies. If there is a suspicion, if there is a distinction needs to be made between influenza and COVID-19 infection, which is the major confusion, then the person will be tested and they will look for presence of a particular virus. They will test, is the virus that's present influenza virus? Is the virus present COVID-19 virus? And those would be the tests that you get if you have already been, you know, they insert a swab into your nasal passages, swirl it around, and that is then tested for the presence of virus. There are various tests which are all pretty reliable to identify the virus itself. So here's how the disease actually progresses in human beings. And I'll just emphasize, you do not necessarily move through all of these stages. The virus can arrest at any particular point. Your immune system may be able to recognize it early enough and deal with it before it proceeds through the different stages. So first of all, in stage one, in many ways, this stage one is what makes this virus so incredibly dangerous. COVID-19, by the way, the 19 comes from the fact that it was identified in 2019. In stage one, this is early infection. And if we see the first 5 days or so of the infection, you can in fact reach quite high viral numbers in the body without producing any symptoms. This is why the virus is so dangerous, because people can be walking around with no or very mild symptoms and actually shedding virus. The virus is already actively replicating in the body and is being shed. I'll show you how to shed in a minute. And this means that they can be spreading the virus to other people without even being aware of it. In the other SARS associated viruses, SARS CoV-1, at this stage here, the people are already extremely ill, and they are probably bedridden, and their disease is recognizable. They do not spread the virus. They are very, very quickly contained. And that is the huge difference between them and this virus. In fact, people can be moving around throughout the stage one, can continue operating, and people do. Essential workers, for example, people who are dependent on a wage, people who feel obliged to go to work even when they are ill, may continue working, moving through the population all through the stage one. So this is the time when the virus is replicating very, very rapidly inside the body. But all the symptoms are mild or absent. You can still, if you were tested, you could very easily pick up that the virus was present. but your body is busy mounting a very strong antiviral response. And you may, in many, many people, the infection will terminate here. The immune response is sufficiently strong that it deals with the virus just as it would deal with any other virus, and that is an end of it. For many people, that appears to be the course of the illness. But for some people, the virus will proceed. The immune response is not powerful enough to overcome this very powerful virus. It's reproducing extremely rapidly. And people then move into a pulmonary phase. The virus now moves down into the lungs, away from the upper respiratory tract, into the lungs, and also begins to spread to other parts of the body as well. Still, you may arrest, you may end the infection here. Somewhere many people do. They end with a cough, that sort of thing, and then the disease terminates for them and they go into convalescence. But there is something extremely dangerous that appears to begin to happen in this stage 2, and that is that the immune system sets up a very powerful inflammatory response. Now, that inflammatory response is a result of release of immune hormones by the white blood cells. And it excites the immune system and results in very profound changes throughout the body. In particular, in the lungs, for example, the blood vessels in the lungs begin to dilate. And remember that in inflammation, blood vessels dilate, they become leaky. They begin to leak fluid. And in this case, the lungs fluid, that fluid begins to accumulate in the lungs. There appears to be, in some people, a stage 3, which is called the hyperinflammatory phase, where the immune system essentially goes into overdrive. And it begins to react, particularly in lung tissues and in blood vessels, to cause a constant, very high-pitched inflammation. And this actually ends up being very, very dangerous and is very often what kills the patient. The patient in fact, dies as a result of this storm of immune hormones, which goes uncontrolled, becomes uncontrolled. And this you'll see referred to as a cytokine storm. And many, many, many of its effects appear to be on the lungs and on the circulatory system. And it produces a crisis situation. It is at this stage very often that people go into respiratory distress. They become unable to absorb enough oxygen into their blood. It's at this stage that people will be put under high pressure oxygen or maybe intubated, and in an attempt to keep them oxygenated enough that they don't end up dying of oxygen deprivation. But unfortunately, this is such a powerful response that it is if people enter this hyperinflammatory phase, they very frequently die. So again, just to summarize, most people remain in stage 1. That is the normal response. Normally, the immune system is sufficient and remains sufficiently controlled that people end the disease in stage 1. It is still extremely dangerous because they are able to spread the disease. Quite a lot of people enter stage 2. That is the stage where they develop dry cough, respiratory symptoms. Nonetheless, many people still end the infection here and go into convalescence. But a certain proportion of people mount such a powerful immune response that the immune response actually results in this hyper-inflammatory stage, which is what, in fact, has killed many, many of people who've died as a result of COVID. So here are some of the reasons why this disease is so easily spread. It's just an unfortunate feature of our biology that as we breathe, talk, laugh, sing, sneeze, cough, whatever we do, we produce a continual cloud of droplets of moisture, which we expel from our mouth and from our nose. This is somebody not sneezing or anything. This is probably somebody shouting or talking loudly, whatever he's been asked to do. And it's just lit in such a way that you can see the droplets. And you will immediately notice something. That is that there are different size droplets. Look here, and you'll see the dropping out of this cloud here are large droplets. But here are kind of medium-sized droplets, and misting up here, like a mist, like a fog, are very, very small droplets. So we produce a wide variety of droplets, and they have a different natural history. The large droplets tend to fall very quickly. Smaller droplets remain suspended. Very small droplets can remain suspended for a long time, for a very long time. And they can, in fact, remain suspended in the air for between 8 and 14 minutes. That is, all of these medium-sized and small droplets can remain suspended in the air and circulate in a space for 8 to 14 minutes. It's measured by experiment. Just the most ordinary activities produce these droplets. And so talking, coughing produces a huge amount. Sneezing produces the most. And sneezing, in fact, is the most dangerous because it produces droplets from the upper respiratory tract as well as from the lower respiratory tract. Coughing tends to produce from the lower respiratory tract and the mouth. So we can produce a huge amount, especially if we're symptomatic, coughing and sneezing, producing masses of these droplets which enter the airspace and go into circulation and can be picked up by other people. So here, just to give you an idea, those very small droplets are called aerosols. They are less than 5 microns in diameter. Just to give you an idea, that is smaller than a bacterium, right? The common bacteria are around about 5 microns long. So these droplets are smaller than a bacterium. You can't see them with the naked eye. But remember how small viruses are. A droplet this size could contain thousands of viral particles, enough to establish an infection. These aerosols, remember, remain up in the air for nearly a quarter of an hour. They've been recorded, circulating around, and they can be swept away far in that time. They can be swept far away from where they originated. The danger of these is that they can remain infectious far greater than that 6-foot distance that we are used to thinking about. The droplets that are the medium-sized and large droplets are a different matter. They're greater than 5 microns in diameter. They tend to fall and to fall out and towards the floor of the surfaces within 6 feet, within 6 feet distance. That is where our 6 feet rule comes from. So we're protecting our social distancing. This is what we're protecting ourselves from, primarily. And masking, we are trying to protect ourselves from these and these. That is why we emphasize the use of masks. First of all, the mask stops the release of most of these aerosols from somebody who is infectious. You contain them. Second of all, somebody who's not infectious, who is masked, will be protecting themselves from both these and from these. There is something else in our recommendations. First of all, masking. Second of all, social distancing. Well, social distancing it does two things. First of all, stay more than 6 feet distance. You protect yourself from picking up many of the droplets. But also, if you limit the number of people who enter a space in a certain length of time, you limit the number of aerosols that keep on circulating in that atmosphere. So that is the second component to social distancing, limiting the number of people in a given space, in a given time. You limit the number of aerosols which are going to be produced. There's one other feature, and that is that these droplets can settle. There is some controversy over how long the virus remains infectious from a surface, but we do know that there is certainly a time when the virus will remain infectious when it settles on a surface. Any inanimate object which can pick up infectious agents and harbor it for a while, we call a fomite. A table is a surface, is a fomite. A door handle, that's a fomite. We are unsure about how long they remain viable. But one thing we do know, and that is if you have viral particles on your hand, and you then do something like rub your eye, or pick your nose, or put your finger in your mouth, you can directly transfer virus from your hand to mucous membrane where it will start to reproduce. This is the importance of hand washing. We can very easily pick up virus from surfaces, and we can also pick up virus from our own surface. If we had, say, you had a droplet land on your cheek, as long as it sits on your cheek, it's not going to do anything. But if you move that to your eye, then you could infect yourself. Hand washing is extremely important as a preventative measure. Masking is our primary weapon against both spreading virus. That is its most important effect. People who are asymptomatic and yet able to spread virus, they vastly limit the amount of spread by wearing a mask. They don't reduce it to nothing, but they substantially reduce it. And the other aspect of masking is if you are uninfected and wearing a mask, you limit the number of droplets which you will inhale. You will not limit the number of droplets that land on you that you could possibly spread with your hands. Sterilize your hands often. But if both infected person and uninfected person are masked, the likelihood of transmission by droplet between them is very limited. That's why we emphasize you mask primarily to protect other people in case you are infected. You mask secondarily if you are uninfected to limit your uptake of aerosols. Now, currently there are indeed some treatments. Remember, there is no antibiotic for a virus. There are, in some viral infections, we have developed treatments which do directly affect the virus and limit its infectivity. But in this case, we have nothing that would do that. And there is no antibiotic to a virus. A virus is not alive. You can't use an antibiotic on a virus the way you can on a bacterium. So the number of treatments is somewhat limited, but some of them are very powerful. You'll hear use of this. This is dexamethasone. Dexamethasone, what it does is, let me just go back here. It limits this. It limits the host inflammatory response. It is only used, however, if it looks like somebody is entering this phase. It is not used routinely, because runs the risk of suppressing the normal immune response. It is only used to try to suppress this exaggerated immune response. The second thing is we do now have artificial antibodies produced in bulk, which can be used, and those antibodies attack these proteins on the outside of the virus, and they reduce its ability to infect new cells. And there's mixed success with these, but in some cases they appear to be very effective. The next thing is there is some talk of using serum from people who have recovered from COVID, who have high antibody levels in their serum. And we can use that serum, give it to people who are newly infected, and hope that that antibody will act to inactivate the virus. The results are extremely mixed. There's some indication that in some cases works. Other workers say that the impact is very limited. Nonetheless, this is tried in some cases, especially if people look like they're becoming seriously ill, then it may be tried. But the real answer now lies in developing vaccine. And not only in developing vaccine, but getting people to become vaccinated. If we can get about 78% of the population immune to the virus, then we can end the epidemic for reasons I'll explain in a minute. But that is the aim, to get about 78% of the population immune. Currently, very few people are immune. Only people who've had the disease have some immunity, and it is very unclear how long that immunity lasts. With the vaccines that are being developed, all head for these proteins, these spike proteins on the outside. They use various methods to do so, but all of the vaccines produced so far appear to be quite effective and will start to enter into circulation probably at the end of this year, beginning of next year, and they will probably be made available first to those who are especially vulnerable to the disease, the elderly, people who have cancer, people who are under chemotherapy, those people, frontline workers, doctors, nurses, hospital porters, cleaners, all of those people who are constantly being exposed to the virus, then to the general population, the elderly maybe, and then everybody else. But it should hopefully, we will see it in general circulation by the second half of next year, if all goes well. And then we can begin to breathe easy in more ways than one. So just to remind you what a vaccine is a harmless component, usually a derivative of the pathogen, and it stimulates the immune system to mount a response against the pathogen if it ever sees it. We know vaccines very well. We know that they prevent viral diseases. They're extremely efficient. We've eliminated this disease, smallpox, from the planet by use of vaccines. All of these, mumps, rubella, measles, these are common childhood vaccinations, which have almost eliminated these diseases from the human population. But we need to remember that viruses cannot be treated with antibiotics the way we can treat bacteria. And although some antiviral drugs are available for specific viruses, such as HIV and influenza, we currently have no such drugs against COVID. So our great hope of rapidly ending this pandemic would be to develop good vaccines, and above all, to develop good vaccination programs. No good having a good vaccine if people won't take it. It defeats the whole purpose. Now, I know I'm going on a little bit longer than normal, but bear with me just as I discuss this final part. This is extremely important. First of all, because we need to understand this in order to understand the importance of vaccines in dealing with the current epidemic. But second of all, because this has become a political issue, and people are advancing arguments based on what I'm going to tell you to suggest that our best strategy is simply to allow the virus to spread widely through the human population. It relates to this concept of herd immunity. Now, herd immunity is a concept derived strictly from vaccine studies. And it looks at the way in which disease spreads through a population. Okay, so first of all, let's just say we have a population, much like our population, human population or American population was at the beginning of the year. There's a virus entering the population. Nobody has ever been exposed to it. Nobody has any immunity to it whatsoever. None of those immune systems have ever seen it, so they have no way of dealing with it. It depends on the disease. In this case, in SARS CoV-2 rather, we were dealing with a virus which is highly, highly contagious. It's one of its key features. It's extremely contagious, and people can be infectious for quite a time, spread the virus without even knowing it. This is what happens. We had 1 or 2 people enter the population. This very rapidly, the virus is spreading through the population. So that is what we're watching happening currently. That's why our numbers are so high. The virus is spreading and exponentially as it moves through the population. So now let's just think that maybe we introduce a disease where 1 or 2 people inside the population, a few people in the population are actually resistant. They have some immunity to a disease. Well, it means that if a virus enters the population, it spreads through the population, but it does not infect those who are immune. So we have isolated instances where people might be exposed to the virus, but they don't get it. Not the entire population falls victim to the disease. Let's just expand that idea a bit and think, how did the disease spread here? Well, it spread from person to person, but we would have it spread where maybe one person was infected and spread the disease all the way around. They spread to people close by them. They spread to not just one person, but to several people. Those people, in turn, in their infection, they spread to several people around them. Let's just think about what happens if we have people inside the population who are immune. Well, the spread becomes somewhat limited. It moves more slowly. And in addition, these people who are immune do not spread the disease. So a limitation is placed on the rate at which that disease is going to be spread. As soon as you have people who are immune in the population, you begin to limit the rate at which the disease is spread. Now let's think if we have a population where many people are immune and only a few people are vulnerable. Have a look here. This diagram here, these people in yellow are all immune. The people in blue are susceptible. Now we have people move into the population who are infectious. But most of the people they move amongst are immune. They don't get the disease. They don't get to spread it. And it provides immunity to these few vulnerable people. The fact that most of these people are immune provides immunity to these few vulnerable people, when the disease enters the population. Infectious person comes in, the disease doesn't spread away from them because everyone else is immune. These people here are protected, even though they have no immunity. They are protected by the immunity of the people around them. And that is what we refer to as herd immunity. Now, if we know how contagious the disease is, we have ways of measuring that. We can work out how many people we need to be immune in the population to achieve this herd immunity, which will protect even those who are vulnerable. This is the concept of herd immunity. We get as many people immune as possible. Now, this, remember what I told you, this is related to vaccine science. Vaccine science looks at the population and tries to work out how many people do we have to vaccinate to achieve this situation, where even people who are not vaccinated or cannot be vaccinated are immune because everyone else is immune. That is herd immunity. This was the idea of people who said, okay, why don't we have no vaccine currently available for COVID-19. And this was their theory. Let's just let everybody get sick. Because most people who get sick actually recover. And they have immunity. And if we let enough people get sick, then we will establish herd immunity to the disease, right? So we have masses of people who are all susceptible, but we have people come into the population. We let them infect other people. They will infect other people. Eventually, all these people who've been infected, they will have immunity to the disease, and we'll establish herd immunity, and then the epidemic will end. Okay, using that logic, let's do it. Let's do the math on this argument. The current population of the United States is 331 million people. The current estimate for herd immunity for this disease is actually 78%, but there's some wiggle room on that. So let's be very generous and say we only need 65% of the population to be immune, to establish herd immunity. Well, we've got it. 65% of the population have got to be immune to the disease. How are they going to acquire that immunity? They're going to have to get the disease. They're going to have to suffer from COVID. 65% of this population is 215,150,000 people. Our current case fatality rate in the United States is around about 2%. In some areas it's higher, but let's be generous and say it's 2%. 2% of people who get the disease die of it. What is 2% of 215,150? Is 4,303,000. Our current fatality rate, we're actually up to 270,000 now. But when I did this sum, it was 237,000. That's how quickly it's changing. I only did this a week or two ago. 2% of this is 4,303,000 deaths. We are calling for 4,303,000 people to die in the United States in order that the rest of us of the population can consider themselves safe. Our current mortality, well, it's now, as I say, 270, but here it was 237. That is only 0.001, 1,000th of the people who we need to die have already died. Look at the chaos that has already been created by these deaths. What would be the impact on our nation if 4,303,000 people were to die in order to establish herd immunity? people who are calling for this to be done, and they are sitting on the COVID task force in the White House, are asking for the rest of the population to suffer a fatality rate 1,000 times what we have seen. It would devastate this nation utterly, absolutely, if that was to be done. And when people talk to you, as they will, about herd immunity, you don't need to remember the details of this, but just work through the idea with them about what establishment of herd immunity actually entails. It means some of us surviving at an enormous, unbearable cost, greater than any disaster that has ever befallen this nation before. So that, my opinion of this herd immunity idea, you will gather from the tone of my voice what I actually think of it. Okay, so wear your masks, sterilize your hands frequently, social distance, do not socialize, be patient. We've just got to be patient. We have to be patient for about a year more, and then hopefully science will provide us with a real solution to this terrible, terrible problem. But you are living through history, so make sure that you survive. Okay, and I'll leave it at that for today.